Good afternoon, everyone, and welcome. This is just such a fabulous turnout, so thank you very much for coming. My name is Lisa Jerome. I am the Director of Major Gifts at the Toronto General and Western Hospital Foundation, and I am also a fundraiser working on the Brain Campaign. And so obviously this is a topic that is very important to the work we are doing with our fundraising in the Brain Campaign, and Dr. Tartaglia is a great champion and doing some really important work. So I'm delighted to welcome you all here to learn from her today. I think, and I hope you will be walking away today with a greater understanding of dementia and how we here are making strides in understanding the issue and diagnosis and our treatment. So hopefully you will hear that, and we will have some time afterwards where you can ask questions and have the opportunity for a little bit of dialogue to hopefully address some of your specific questions that you may have. So from behind the scenes, this is a lecture that we do twice a year. This is our 9th year that we're doing it, which is really amazing, and I think this is our biggest turnout we've had yet, so thank you all for coming. So you'll have to stay tuned to our other topics. Our next one is on November 19th, and we will be announcing shortly what the topic is for that. You know, our topics over the years have been transplant, ophthalmology, arthritis, surgical innovations. So what we try to do is feature some of the really incredible work that's going on here that would be of interest and relevance to you. So I don't know if you've all seen the report on your support, which is our donor newsletter. I think it would have been mailed out to most of you. If not, we do have some copies that you can get on the way out. But the feature was Dr. Tartaglia, and that's why we thought it was important that we bring her here today so you can learn a little more about the specific work that she is doing. She is a neurologist at the Crembo Neurosciences Centre Memory Clinic at Toronto Western Hospital. She is a researcher at the TAN Centre for Research in Neurodegenerative Diseases and is an assistant professor at the University of Toronto. Dr. Tartaglia took a scenic route to medicine. She first did a Bachelor of Arts degree and entered the movie industry and was a director for several documentaries. But then she decided it was time for a career change, and so she thought medicine would be the way to go. She did her medical degree at McGill and did training at the University of Western Ontario. Following that, she did a specialty in her clinical and research fellowship in cognitive and behavioral neurology at the San Francisco Memory and Aging Center as part of the University of California. Her specific clinical and research interests are around neurodegenerative diseases with a focus on the frontotemporal dementia, and I'm sure we'll learn a lot more about that today. She is also a researcher as part of the Canadian Sports Concussion Project and is also a guest health columnist at the Globe and Mail, so perhaps you've read some of her articles in the past. So just a little bit about her beyond her professional degree, because I think it's important to get to know her as a person, outside of her research. She is a fitness fanatic and most recently completed the Boston Marathon, which is a huge accomplishment. So congratulations on that. Her ultimate goal for her research is to provide early pathology-specific treatments to her patients at the memory clinic. And so that brings us really to the presentation today, which is entitled Dementia. Accurate diagnosis is the first step towards a cure. So, without further ado, Dr. Tartaglia.
Well, I want to thank you all for coming here, especially on this beautiful day. Obviously, I'm very excited about the brain. I'm a neurologist, and so that's pretty much all I think about. But it's great that I see all these people here who I assume also care about the brain and care about how the brain changes. I also want to thank you guys for your generous support of research because as you all know, we don't have cures for many diseases. We definitely don't have many cures for brain diseases. And really, your brain is who you are, right? Your brain defines you. It's your personality, it's your ability to interact, to have careers, to have families. And when things happen to the brain, well, all those things really do change. So I'm just going to check that everybody can hear me, and it's okay? All right. And I'm going to move ahead. So today I'm going to talk about dementia. And, you know, in some diseases, there's been a lot of progress in the diagnosis. And so, you know, maybe some people know that if you have cancer, people need to know every aspect of that cancer before they even offer you treatment. In diseases of the brain, especially neurodegenerative diseases, which dementia is one, people haven't thought of that. Of being that diligent about finding a diagnosis. And really, many people that I see have had dementia for 10, 15 years, and that's where it stopped. There is no other diagnosis. So dementia is not a diagnosis. It's kind of a syndrome, a change that has occurred, and it, you know, interferes with your ability to function properly. But it's actually the first step. After that, the next question is, what is the cause of my dementia? What is the cause of the dementia in my loved ones? And that's where, as a field, we haven't really moved forward far enough to be able to move towards curing these diseases. And so right now, in my lab and in many labs around the world, we spend a lot of time thinking about ways of being able to diagnose these diseases. So today I'm going to talk about the different types of dementias, the different types of dementia causes, let's say. I'm going to talk a little bit about the biomarkers, the way to make these diagnoses, and also so that you get a better understanding of what is available. There are some treatments available, and they're specific to the different dementias. And also talk about the pharmacological and non-pharmacological treatments that we have. So, as you probably all know, we've actually made a lot of headway in health, and so many people now will be living into, you know, ripe old ages. Let me get the other pointer. So, you know, this is where we're all heading. Our average lifespan now is 85, a little bit less for men, I think it's 83. So there's going to be a lot of people who get to live long lives. Unfortunately, age is the biggest risk factor for developing dementia to date, okay? So many people will live long lives, and there's going to be a lot of people who end up with a neurodegenerative disease that leads to dementia. And so I think it's really important for us to be thinking about what are we going to do about this, right? Like in 2011, there were 747,000 people who had dementia, okay? I'm glad to see there's a lot of women in the audience because unfortunately 72% of those people were women. So we don't really understand why that is, but women seem to be more often afflicted with dementia than men. And as you can see here, it's very, very expensive, okay? Dementia in a society is a very expensive disease. So when people talk about dementia, I often see people in my clinic and you say, well, you know, the person has dementia, and you're about to say, you know, we think it's this, and they'll be like, oh, thank God, I thought they had Alzheimer's disease. And so I'm very much struck by that because it really leads me to think that there's very poor understanding of what dementia is and what Alzheimer's disease is. And really, when we say dementia, all it means is that your brain has changed in some way, okay, that is so severe that you're not able to function the way you used to function, okay? And that's basically it. It has to interfere with your ability to work or, you know, be in your usual social activities. It's a decline. So if you could never do math and you can't do math at 90, we're not going to say that's anything wrong with you. It has to be a change, okay? And it can't be explained by a psychiatric problem or some other issue. And it has to be detectable, okay? So it's not because, well, I don't think I'm very good at this anymore. It's like, no, when we test the person, we can see that there's, you know, obviously an impairment there. You're not scoring in the way that other people of your age and your education are scoring. And usually it's in multiple domains, so it's not just memory. Sometimes, it can be memory and language, or language and visual spatial function, or your ability to organize and think. So things have changed, and it's so severe. But really, it's not a diagnosis, because all you're saying to somebody is like, okay, well, things have changed. Next question should be, and what has caused my change? And really, it's an umbrella term, okay? And so the choices that we deal with, because I specialize in neurodegenerative diseases, there are other reasons that your brain can change. If you had a tumor or a stroke, a big stroke, you would also have changes in your cognitive function or your behaviors, but it would be a different cause. Multiple sclerosis. There's other reasons, but I'm talking about the primary neurodegenerative diseases. And so this dementia is an umbrella term, and it includes Alzheimer's disease, Parkinson's disease dementia, frontotemporal dementia, Huntington's disease, Lewy body disease, vascular disease dementia, and primary progressive aphages. Rarely do we see Creutzfeldt-Jakob disease. This is that mad cow disease, but not the one caused by beef. This is the one that's caused spontaneously. We don't know why. And so when somebody says, they have Alzheimer's disease, it's like, you're in a building, okay? Let's say Alzheimer's disease is the house, but it's different than Parkinson's disease dementia, which is a bank, or frontotemporal dementia, which is a hospital. You really want to know what is the cause, because they're very different. And I think, fortunately, that we're now in a time where people are starting to think that, yes, okay, dementia is not enough of a diagnosis. We really do need to move forward in order to find cures for these diseases. It's very unfortunate that in 2013, so 2 years ago, one of the biggest Alzheimer's trials had 30% of their patients in the trial not have amyloid in the brain. Amyloid is one of the causes of Alzheimer's disease. The people were given an anti-amyloid drug, and the trial was negative. Well, if you had a colon cancer trial, and 30% of the people had, let's say, brain tumors, and you gave them a drug against colon cancer, and then the drug failed, we'd all be sued. That would be completely unethical, unthinkable that could have happened. But in Alzheimer's disease, it did happen, and not that long ago. So now, to get into drug trials for Alzheimer's disease, we need to have biomarkers. We have ways to detect Alzheimer's disease, and you have to undergo a test to prove that you have Alzheimer's disease before you can get into the trial, so you're not given a drug that you shouldn't be getting. And also, strangely enough, in 2011, new criteria came out for all the neurodegenerative diseases almost, because it was felt that, the ones from the 90s and the 80s were outdated, and we probably needed new ones because we had learned some things in, a decade. We also think really very hard now about where is the disease in the brain. It's not the whole brain. Okay, certain networks are affected and other networks are still working very well. And so we think of where is the distribution of the pathology, of the bad proteins that are causing the problem that you have. That we also know, and we're going to go over this, is that these diseases start long before you show any manifestation of the disease. Okay, our brains are very capable of compensating, especially if we have good cognitive reserve, if we've kept our brains active our whole lives, then we're able to compensate. But the brain is still accumulating disease. It's just that we're able to function fairly well. And then I'll go over some investigations and treatments. So why is it important for us to know what is the cause of our disease? Because they're different, right? So the Lewy body, which is the bad protein that builds up in Parkinson's disease, is very different from the one that is in Alzheimer's disease. Okay, in Alzheimer's disease, there's two. There's these plaques and tangles. They're different. Which are different than the ones that build up in Huntington's disease or in the prion diseases. In frontotemporal dementia, unfortunately, there's different bad proteins that build up, and there's right now no way of knowing which one it is. So these are really tough diseases to think about treatment. But we're working very hard to figure that out because, unlike blood diseases, we don't take pieces of brain out. you need all the brain you have. And so we cannot do biopsies to figure out what the bad protein is. ALS also falls into this category. When we look at 100 people with a neurodegenerative disease that have generously offered their brain for research, we see that usually 40% will have Alzheimer's disease. And the other 60% have something different. So it's not good enough to just say everybody has Alzheimer's disease, because it's not true. And unfortunately, these people, over here would have all ended up with the wrong treatment if somebody had thought that they had Alzheimer's disease. So what about Alzheimer's disease? So Alzheimer's disease is really a disease that people think of mostly related to memory problems, okay? So that's the most common presentation, is people's short-term memory starts to fail them. They're really good with memories from long ago, but you give them some information and all of a sudden they can't remember it, okay? They're losing things, they might repeat themselves or leave appliances on. But we now know that it's not that uncommon for people to have Alzheimer's disease, and it presents in a different way. So some people will present with only language problems. So their memory for words has failed. Their memory, like their visual memory, will be very good, and they'll be able to navigate everywhere. But you ask them to say something for you or to have a conversation, it's very, very difficult for them. Some of them, in fact, have only a visual presentation. Their language memory is very good. They can have great conversations, but they can no longer see well. Even though their eyes function properly, they can't locate things in space. And when we look at the brain, we know that it's Alzheimer's disease also. Okay? There's also some people that present with more of an executive dysfunction. So that means that their memory is okay, but they cannot remember, they cannot plan things properly, their judgment is off, they're not able to function in the way that they were before. Oops, yes. So this is imaging that is done. So these are MRIs of people's brains. They're looking straight at you, okay? So this is actually the left, and there's the right. And so this is a 65-year-old person. Their brain doesn't look like it did when they were 30, because our brains start to shrink little by little when we're 30. But this area over here, these are your hippocampi, your organs for memory, okay? They look quite good. This is somebody with mild cognitive impairment, okay? There's a little more space than the normal 65-year-old. All over the brain, they've lost a little bit of brain tissue. When you lose a little bit of brain tissue, it's actually replaced by the black here, and that's fluid, okay? It's a kind of a shock absorber of the brain and cleans the brain out. So there's a little bit more space. These people will tell you that, their memory is not that good. They're not like they used to be, but they're still functioning. They're living on their own. They're able to do many things, but, they probably have to take more notes and a bit of problems. This is a brain of somebody with Alzheimer's disease, okay? So these areas of black, that used to be brain before. And now they've lost so much of their brain cells that it's been replaced by the fluid. And so, we do have ways of diagnosing this. Unfortunately, this is quite late in the game. We would not like to encounter people at this stage of their disease. We like to see them earlier on so that we could actually, do some interventions. Vascular disease dementia is actually a relative newcomer. It used to be thought that you had to have a stroke and 3 months later you'd have, dementia. And everybody knew that there were many patients who could swear they never had a stroke, and their families would tell you they never had a stroke, but their cognition, their ability to remember and to plan and organize was really not that good anymore, and they were doing fine before. And so in 2011, which is not that long ago, people decided that they had to revamp those criteria. And so now you are allowed to have vascular disease dementia and never have had a stroke. Okay? And the reason that you have it is because you're accumulating vascular disease, which is basically the blood vessels in your brain are becoming more and more unhealthy because of high blood pressure, because of cholesterol, because of diabetes, alcohol, sedentary lifestyle. Okay? So these are a lot of these things are modifiable. So this is the one disease where we have a lot of control over this. And so, you can start off and you have little of it, This is, you shouldn't have this, but it's not that much. But over time, if you don't take care of yourself, you end up with lots of this. And that means that your ability to process information and to, do the things you used to do will not be as good. And you'll become slower, your thinking becomes slower, your movements become slower, and that does translate into not being able to function, well enough to even be able to take care of yourself. And so you could end up initially with vascular mild cognitive impairment and eventually with vascular dementia. These are the Parkinsonian dementias. So there's a Lewy body one and a Parkinson's one. These people, their whole brain shrinks. There's no particular pattern. There's shrinkage of the whole brain. It's not as bad in certain areas as an Alzheimer's disease or frontotemporal, but their whole brain is shrinking. And depending on the symptoms, we either call them Lewy body or Parkinson's disease. So if you have Lewy body, it means first you're having cognitive issues and you're having hallucinations, and over time you become slower in your movements. The opposite happens in people who have Parkinson's disease. So you have Parkinson's disease, you have the tremor, you're a little bit rigid, you're slow, but your thinking is very good, and you're still able to function cognitively very well. But over time, you can accumulate, and not everybody does, but you can accumulate cognitive issues. And so as the disease progresses and ends up in areas of the brain important for cognitive function, like memory or thinking or language, you end up with a dementia. And so we call that Parkinson's disease dementia. Frontotemporal dementia is a kind of a family of syndromes, and the original ones had 3 syndromes. Now we have 6. And one of them is a behavioral variant. So like the word says, it's all about personality changes. The front of the brain changes and the back of the brain looks pretty good. And because of that, these people become very, very apathetic. They lose empathy. They change the way they eat. They either overstuff their mouths or only eat certain foods like sweets. They become disinhibited. The very sweet, caring people will start to act in ways that are completely socially inappropriate. And that's because this part of the brain doesn't work as well as it used to. Their memory actually is quite good. These people have what we called semantic variant primary progressive aphasia. That's because this left anterior temporal lobe, because this is reversed, starts to degenerate. Okay, and that's where the meaning of your words lives. And so you can lose meaning altogether. You don't just lose the word; you actually lose the meaning of the word. It's very difficult for these people. Some people, their meaning, their comprehension is very good, but they can't get words out at all. They really, really get stuck on the word, and that's because this area of the brain, which is what we call the left inferior frontal gyrus or Broca's area, doesn't work as well because they're accumulating bad proteins there. And that means that they're not able, they know exactly what they want to tell you, but they can't tell you. And they can't write it because those things are connected. So this is just to show you that, when we do MRIs, when people have reached certain stages of diseases, we can actually make very accurate diagnoses of what it is that is causing your particular type of dementia. Okay, these brains all look very different. Okay, and it's just that most of us think, you shouldn't have to wait to this stage of the disease. You should be able to find that the person has the disease earlier on. So in Alzheimer's disease, actually, we're quite fortunate. We have 2 ways of detecting, determining that you have Alzheimer's disease pathology in the brain that's causing your dementia. One of them is looking at the cerebral spinal fluid. So that's doing a spinal tap. That fluid, that black stuff that I showed you around the brain, that's fluid. It's clear, usually like water. We don't go in the brain to get it. We get it below the spinal cord. And I do this routinely because I see lots of people who have maybe an atypical presentation or even a typical presentation, but they would like to know if they have Alzheimer's disease, and we can determine that. The other way is to do PET scans. These aren't readily available clinically. They're done for research all the time, but they aren't clinically available. But with that, we're very good at diagnosing Alzheimer's disease when we do these types of tests. We know now that it's very important to think about these diseases early on in the disease course, okay? Until recently, nobody realized this, that you're actually starting to accumulate amyloid and tau long before you have any sign, okay? And so this is basically showing you that, you know, before you show any signs, even of a mild cognitive impairment, there's 20 to 30 years of accumulating this disease. And really, that's an opportunity, right? And once we have treatments, it'll be easier to say, well, you know what, everybody should get tested. When we figure out that you have this accumulation in the brain, we will start to treat you. For the first time now, there are actually clinical trials in the world where people who have no sign of disease, okay, they have, you know, they've been tested, you know, very extensively, and they are perfectly cognitively normal, but they have building up of bad proteins in their brain. These people are now in clinical trials, okay, to see whether we can actually either delay the onset of the disease or actually, you know, prevent it altogether, okay? In some cases, it's people who have the genetic cause of Alzheimer's disease, which is very, very, very rare. And in other people, it's just that they show that they're accumulating these proteins, and we'd like to stop them. And so this is kind of saying the same thing. So mild cognitive impairment is, you know, generally a recent phenomenon for us, because not that long ago, only people who were severely demented came to our clinics. But now there are young people, there are people at early stages of the disease who come to us and say, you know what, I'm just not like I used to be. I used to be, you know, very sharp and quick, and I could remember everybody's phone number, and all of a sudden, I'm not like that anymore. And so we can, you know, talk to them, and we can test them, and we can see that, yes, their cognitive function is not the same as other people of their age group. And this is true for people in their 50s, they can be in their 60s. I see people in their 90s. You know, and sometimes it's very tough. I had a physics Nobel laureate who was 92, and he's like, I'm just not as sharp as I used to be. And I was like, well, yes, I'm sure you're not, but we're not detecting it because, you know, most of us can't even aspire to that. So, you know, the tests are not, you know, foolproof, but we do believe you when you tell us that you're not what you used to be. But these people, different from dementia, are functioning very well in their daily lives, okay? Maybe if you ask them to perform, you know, at the peak of their careers, they wouldn't be able to, but they're able to take care of themselves and manage their finances, manage their household, do everything for themselves. But it's not normal aging, okay? This is not the same as somebody who, you know, every now and then has a word at the tip of their tongue and can't get it out. Okay. So we do encourage, you know, family doctors to test people if they're complaining about a cognitive change. And there's many tests that are readily available on the internet. You know, most people know about these cognitive tests, and they don't really take that long. But obviously, it's not a 5-minute assessment of your brain. So, you know, we do think that their accurate early diagnosis is important, and we do feel that, you know, we have made some headway. In Alzheimer's disease, we can detect these proteins. In vascular disease, you know, the MRIs are very good for showing us disease. In Parkinson's disease, dementia, we have the symptoms, obviously, and we do have these types of scans that are not readily available, but are gaining, you know, momentum. Same thing for Lewy body. And frontotemporal dementia, unfortunately, is still, you know, a little bit behind, okay? Because there are 3 different bad proteins that can cause these diseases, it's very tough. And, you know, we're all thinking there are treatments coming down the pipelines, and how are we going to give them to the right patients, okay? Like I said, in frontotemporal lobar degeneration, there's actually 6 different syndromes that you can present with. There's a behavioral one, there's 2 language ones, there's 2 that are movement disorders, and there's one that is frontotemporal dementia with motor neuron disease. So these people have both frontotemporal dementia as well as ALS. Very unfortunate, okay? And the lines are just telling you that, you know what, when you have a person in front of you and you're trying to figure out what is causing their syndrome, what is causing their disease, it's very difficult, okay? There's nothing about the presentation that will help us. And that's a problem because, like I said, the way we think about dementia now is we need to go with protein specific. So we need to know what is causing your problem and how are we going to do that. That's actually the basis of my research program. I combine different methods of imaging. I combine that with your blood, your genes. I combine that with cerebral spinal fluid, the proteins in there, and with eye movements. And we use, with computer scientists, we use a machine learning approaches to try to, be able to guess what is the cause of your disease early on, and be specific about it, so that when these treatments are available, we'll be able to give it to the right person. So let's talk a little bit about treatment. So really, in my mind, treatment of all dementias is, starting off with an accurate diagnosis. You really want to know what is causing your disease. It's not all Alzheimer's disease. The other thing is to educate people. Okay, there's a lot of focus on the cognitive issues, and obviously, losing your memory is terrible. But there are other issues that are actually as important, if not more important, than memory issues. Changes in personality are a big problem for our patients and a big problem for the caregivers. Okay, these people lose their judgment. These people sometimes become agitated. If they don't recognize people, they can act inappropriately towards them. And usually, this is what ends up causing the biggest distress for people. Driving is a big one for us, a big problem. And we talk a lot about non-pharmacological approaches because, I prescribe exercise for everybody, and honestly, we'll go through later some evidence for that. Obviously, good sleep. There's a lot of stuff that we think is kind of common sense, but unfortunately doesn't get done for some reason. There is no evidence for herbal alternative remedies. And I have to say that, I spend a lot of time talking about, proper diet and exercise, and then at the end, somebody will tell me if I believe in alternative therapies. I think, those are as alternative as you can get, and they have no side effects, but honestly, they don't come in pill forms. Speech pathology assessment, physio, occupational therapy. We teach about tolerance for behaviors that are not dangerous but could be disruptive. Obviously, getting people safely home. There's a lot of wandering that happens in all of the dementing diseases, and so it's important to keep people safe. Provide distractions. Support the caregivers, the families. Talk about advanced care planning, and that's one of the important things one of the things we think is very important about diagnosing people very early on, because when they're in a stage where they can think about what they want for themselves later on, that's when they should be asked to make these decisions, because when you leave it to the families, that's very distressing. Okay, we don't have a good grasp of palliative care in neurodegenerative diseases like we do in cancer. They've made a lot of headway, and so we often end up with really very unhappy situations for people, and distressing for everybody. So we don't have any medications that cure or delay significantly the progression of any of the dementias, okay? But we have medications that help symptoms. And we, like in all diseases, we have to treat all the other conditions that are contributing, because unlike other diseases, any disease that affects other organs in your body, that affects the rest of you, will have an impact on your brain, okay? And your cognitive deficits, your cognitive impairments, your ability to think or remember or speak, will be impaired if you have an infection. Will be impaired if you don't sleep well, will be impaired if you're having seizures or you have pain. And so we really do think that treating those conditions will actually help you, will benefit your cognitive function. That's the same for the depression, the anxiety. I mean, think of yourselves, if you're anxious in a situation, you can't remember as well because you're actually, maybe unable to take in the information, and then to ask your brain to recover it when it never got in there is really unfair. So for Alzheimer's disease, the mainstay of our treatments are these agents called acetylcholinesterase inhibitors. So Aricept is the most common one, but there's a family of them. The other one is an NMDA receptor antagonist. These are not cures. They are minimally disease modifying. So on a group level, you do see that the disease is a little bit slower than it is when you don't take these medications, but that's at a group level. Individually, this is not easy. We have a number of trials. I mean, these are multi-billion-dollar industries. People really, really, really want to find a cure for Alzheimer's disease. This is a worldwide, global problem, and so there's a lot of investment. We have many trials against amyloid, one of the bad proteins of Alzheimer's. We have a few trials on tau. We know that tau is also very bad, and it's what is really causing the deficits. We have some combo treatments coming down. And so I am optimistic that we will find something. If it's not a cure, it will at least be able to modify this disease in a significant way to slow down the disease. Vascular disease dementia, like I said, there are a lot of lifestyle modifications we can do to actually slow down that disease, which really, if you had to pick one, that would be the one you want, because you could do something about that one. You can control how it progresses, okay? If you can, controlling of blood pressures, of sugars, of cholesterol, trying to exercise, cutting down on alcohol, quitting smoking, all those things will really impact this disease. Frontotemporal dementia, we often give an antidepressant called serotonin selective reuptake inhibitors. It seems it helps with some of the obsessive behaviors that can develop. We have a number of trials really targeting the different proteins that cause these diseases. And so we are optimistic that we will have something that will be able to at least slow down the diseases in the next few years. We really, really are advocate against giving the acetylcholinesterase inhibitor. So this is one of the reasons that you want to make an accurate diagnosis. I often see patients in my clinic who have frontotemporal dementia, and the physician who first saw them didn't know what it was, or thought, well, I'll give them something, it can't hurt. Well, it actually does hurt them. These people don't have a deficit of acetylcholine, which is seen in Alzheimer's disease. So they often will get very agitated if you give them this molecule where they don't need it. On top of that, if they develop frontotemporal dementia with motor neuron disease, they actually can have trouble swallowing, and this increases the secretion, so you can actually choke on your saliva. It's not a good thing. For the Parkinson's diseases, we often will give Parkinson's medications, obviously, and some of these people actually have two diseases. They have Alzheimer's disease and Parkinson's disease, and so this acetylcholinesterase inhibitors help. So I'll skip that. So the other treatment avenue that we think about is that caregivers have to be taken care of, okay? For us in neurodegenerative diseases, the caregiver is a treatment. A lot of our patients are in the community, they're in their homes, and so they need much more help than they did before. And so taking care of the person who's taking care of our patients is really important to us. People who are taking care of somebody with a neurodegenerative diseases have, special challenges. There's personality changes, there's behavioral issues. And so we often see that some of these people are getting depressed or ignoring their own health. And so we encourage them to protect their health, to look for signs of depression, to ask for help whenever they can, use support groups, use community groups, and really to get as much help as they can. I'm going to spend the last few minutes talking about a new strategy. So like I alluded to, there are new strategies in neurodegenerative diseases, and we now know that some of these alternative therapies are actually quite beneficial. So the one that I think most people hear about is cognitive enhancers, or cognitive activity. And so there is quite a bit of evidence that keeping your brain active is good for you. Okay, so I'm glad to see people here, and hopefully you're learning a little bit, and that will help your brain build up some cognitive reserve. The other one is exercise. Okay, there is a lot of evidence. It's unfortunate that there's no company marketing exercise, but there is a lot of evidence. I mean, when you look at these studies, they are huge. There are almost 20,000 nurses who were in this study, 10,000 women here, 6,000 over here, and all of them, you see the same thing. The more physical activity they did early on in their lives, the better their cognitive activity later in life, okay? So there is a lot of evidence that when you are older or in midlife and you're exercising, that this correlates with better cognitive activity. These people have faster processing speeds, their memory is better, their visual attention, their auditory attention is better, and they move better. It's kind of a given. And that even people who are going to get dementia, you can actually delay the onset of their neurodegenerative diseases. In people who have the disease, okay, there was less evidence. The studies are much more inconsistent, and if anybody knows somebody with, some of these dementias, it's not easy to get people to exercise and keep exercising when they actually don't know why they're doing it, or they can't remember. Even sometimes they agree, but then they don't recall what the point is. I mean, when you exercise, you know what the goal is. And so you keep doing it, even though when it's not fun and, you think it's tough and, maybe a muscle hurts, but you do it because you keep the goal in mind. These people sometimes forget, and so it becomes tougher. But when people have started to combine all these studies, they too started to see that, yes, physical activity was associated with slower disease and better function, okay? And so far we have, these are kind of like the hints that we have, is that, if more intensity rather than longer duration is better, okay? Aerobic type is better over resistance. Moderate, so 1 hour a day, 3 to 5 times a day, 3 to 5 times a week, could be better for improving cognition. And this study actually was done in Alzheimer's disease. In vascular disease, dementia as well, there's a lot of accumulating evidence that, you want to be exercising, that this is good for your brain. It makes more sense in vascular disease, and I'll talk a little bit about that afterwards, but people think, well, obviously exercise is going to be good for your heart and your blood vessels, and so obviously it'll be good for the blood vessels in your brain where there's tons of them. So why is exercise good? Well, we know that it reduces the vascular risk factors, like I've said. So it reduces hypertension and diabetes and cholesterol and stroke and obesity. So it's kind of, given that it would be good for the brain also. We know that exercise promotes new blood vessels. The brain has many, many vessels, but having more vessels is not a bad thing. So there's evidence that some of what happens during aerobic activity actually promotes new vessel growth. There's evidence looking at the different structures of the brain. So I told you that the hippocampi, these structures that are important for memory, actually when you put people through an exercise program, a normal person for 1 year, they actually saw increase in the volume. So, we often don't think that the brain can increase in size, that, cells only die, but actually there's increasing evidence that you can actually help grow cells, okay? Not in the whole brain, though. So interestingly, it was specific for the hippocampi. There are other parts of the brain that did not change with the exercise. So it seems like, different structures in your brain have different receptors. They have different amounts of blood vessels. They have different ways of receiving, the nutrients. And so this part of the brain responded to aerobic activity, whereas other parts of the brain less so. This is looking at connectivity. So our brains are networks and they're connected. Different parts of the brain are connected, and aerobic activity also here increased this connectivity. So we can think of, processing a little bit better when the brain, certain networks of the brain are better connected. And this too was 3 times a week aerobic training in sedentary older adults. And one of the factors that we think is mediating this benefit is this molecule, which is so original in its name, called brain-derived neurotrophic factor, which just means a good thing for the brain. And it's secreted throughout the adult brain. We know it goes down in Alzheimer's disease. We know that if you progress faster, if you're a faster progressor, Alzheimer's disease, you have less. And that we know that aerobic activity increases this molecule. And so this is one of the molecules that many of us, try to measure and, try to find ways to increase. Some people are trying to do it with drugs because it's thought to be a mediator of dysfunction. And so, this is just to say that there's lots of, exercise mediators or, factors that help with exercise, one of them being reducing the vascular risk factors. The other ones are, helping with the blood vessels, helping connections be made, helping new nerves, decreasing inflammation. And so, there's lots of evidence that, exercise is good for us. And, both in I think many of us have heard on the news, especially more recently, all the good, things that can be associated with exercise. It's just that it's easy to ignore because it doesn't sound as scientific as telling you that in this pill there's all these like little molecules and compounds, and these can help you with this, that, and the other. So I actually run an exercise program for people who have Alzheimer's disease. They all have mild to moderate disease, and they're enrolled in a 6-month program where they come to the cardiac gym in our hospital 3 times a week, and for 40 minutes they're on a stationary bicycle. The kinesiologist has designed a program based on their baseline. They get MRIs at baseline, they do cognitive testing, we talk to the caregivers, and we repeat everything 6 months later, and we're analyzing this data. Initially, I thought it would be very tough to recruit, and it did take a while to get started, but actually, at times we have too many people because we don't have a gym for brain rehab like we have for cardiac rehab, and I've had to use their gym on their off hours, and I have very few hours to offer people, and still they come. So I'm very happy that we've had such an eager interest. And what we're looking at now is we're analyzing some of the data. So we're looking at the brain changes, as well as we're looking at some of the cognitive scores. And with 5 people, it's too small of a sample, but we're still optimistic. So to summarize, I think neurodegenerative disease is a group of diseases that really you want to be thinking about what is the actual cause of the problem. We do have some ways of diagnosing the disease, so I don't think we need to continue with just using the word dementia and leaving it at that. I think that this is the time of the brain, and we really do need to get an accurate diagnosis, like in all the other illnesses. And there's, a lot of research being done in all the brain diseases, and I would encourage you to participate as much as possible and donate of your time for research, and that there are protein-specific treatments coming, and they aren't that far away. And so we'll definitely need to figure out ways of diagnosing people of their specific disease and early on. And that, we really have to think of non-pharmacological treatments because these have an effect on the brain, okay? They're like pills. Everything around us affects the brain and changes neurotransmitters, changes the brain structure, changes the brain biology. It's not true that you just have to put it in a pill form, okay? For us, it's really important to be taking care of the people who are taking care of our patients, and so we think of it as a treatment also. So now, thank you for listening.
Okay, we do have time for some questions, and we have some microphones right here at the back. So if anyone has a question, please raise your hand, and we'll bring over a microphone to you. Okay.
Thank you. This is really informative. I'd like to go right to the beginning about addressing confusion in an individual who has shown a lot of resistance to some of the markers that, there's confusion, there's change of personality, and yet when you bring it up with that person gently, they show a lot of resistance. How do you bring them into a treatment program?
Yeah, it's very tough, right? Because one of the things that changes when our brain changes is our judgment. So when your foot hurts, you know you should go see a doctor, you know, if you have stomach pains. But when it's your brain that has changed, your judgment is also not as good. Your insight goes. And we struggle with that. And our families struggle with that too. And, you know, sometimes they end up in our clinics because, you know, they're brought there because, you know, they'll have some other problem and be like, well, you know, this doctor will take care of, he's going to look into this also. And so it's not maybe the most honest approach, but at least they get some kind of assessment. And we often will look at other things too, or at least say, you know, yes, you need to see the gastroenterologist for that. But yeah, it's a struggle, you know, so that's why I encourage people to get investigated, get looked at early, because early on, many people do have insight. They know themselves that something is not quite right. And so at that point, that's when they should be getting help and getting a diagnosis. But when it goes too long, it's true that, you know, their insight goes, and so it's a real struggle. I think there was this person over there. Thanks.
Yes, thank you, Doctor. Did you say early on that there is not a very strong link to the genetics in terms of developing Alzheimer's?
That's right. For Alzheimer's disease, there is, so genetics, we have different ways of thinking of genetics. So genetic mutations, which is a bad gene, okay, is less than 1%, really, you know. In some, like in young onset, it's obviously a little bit more, so 1 to 5%, but in regular run-of-the-mill, 85 years old, getting dementia, it's not that common to find a genetic mutation. That your genes are contributing to developing Alzheimer's disease, yes, they probably are, but not in the way that we think about being able to fix that. So, you know, there's this one gene called ApoE, okay? And if you have two ApoEs, you can have ApoE2 or ApoE3 or ApoE4. If you have two ApoE4 copies, you have 10 times the risk of getting Alzheimer's disease in the general population. That's just the risk. It's a probability. You know, it doesn't mean you're going to win the lottery, and it doesn't mean you're going to get Alzheimer's disease. There's many people who have two ApoE4s, and they'll never get it. But that makes us think there's obviously a genetic component to it. It's just not clear how it's manifesting. I can't tell. Oh, sorry.
First of all, Dr. Tartaglia, I want to thank you for your tremendous dedication and your overwhelming analysis. I don't know how everybody else is feeling in this room, but I feel an impending sense of doom. But
Sorry.
But I do have a few questions. I've read in the paper that there are several societies, several countries in the world whose citizens remain mentally healthy until well into old age, and that probably has a lot to do with their diet and their lifestyle. Mm-hmm. And I'm wondering how we can de-stress, I mean, there's exercise and diet, our frantic lifestyle here. And secondly, sometimes people are mentally healthy, but they have a mental illness.
Right.
There's an overlapping.
Yeah. So for your first question, a lot of the countries you're alluding to are Scandinavian countries, where a few decades ago, there was a lot of promotion of lifestyle modifications and health. And so their incidence of dementia in general has not risen to the level that they had forecasted. And they think it's because they're promoting taking care of your health. Blood pressure is very well controlled. People exercise. I just came back from Amsterdam. Everybody and their mother is on a bicycle all the time, and get out of their way. Okay? These are very important factors, and we cannot stress enough how important it is to take care of yourself. You are responsible for your health, and what you do today will impact your brain later on. And so I think it's very important to really not undermine how important it is to take care of your diet and your brain health, to learn things. I send all my patients to classes, go take seminars, go learn something new because it's exercise for the brain, just like physical activities for the brain. Your second question, which is, mental health. Yes, sorry. I was so gung-ho on that one, and then I was like, okay, let me get the other one over with. So mental health is related to the brain, right? So people who have mental health issues have changes in their brain function. It's just a different type of change than the change that occurs in neurodegenerative diseases. But depression is a change in certain structures of the brain, certain chemicals of the brain, and that is what causes their depression. And there's lots of evidence, for lifestyle in that too, but, most of these people do need some, chemical help.
I just have one other comment. In some countries like India, people go to the top of the mountain and meditate.
Well, let me tell you that I just came back. I was in India in January, okay, at a neurodegenerative conference giving 4 talks. And one of them was on vascular disease, and one of them was on Alzheimer's disease, and 2 on FTD. And they are very worried because in India, in the last decade, their lifespan has gone up by 10 years. So their average lifespan now is 69 years old. And so their people are developing neurodegenerative diseases, and they are unprepared because until now, they weren't worried about that, right? There were a few people who had dementia because there weren't people living that long. But, the population of India is huge. And so it's a big problem out there.
I think we have one more question.
You mentioned that cognitive activity is very important to delay the onset of any form of dementia. Some years back, there was some question as to whether highly educated people were more likely to develop Alzheimer's. Could you comment on that, please?
So we know that education protects the brain against dementia. So people who are highly educated, and I don't mean just formal education, highly educated in the sense of have used their brain throughout their lives, learning new things, those people seem to be protected. Their disease usually starts later, and it seems initially to go a little bit slower because they have what we call cognitive reserve.
Sort of aligning with the previous question, cognitive exercises like puzzles and games, do they help? And if they do, what kind of games and how much? And
Yeah. So there is no evidence for games, and I don't know how many of you have heard of Lumosity. I was very happy that recently on Marketplace they did a whole series on it. There is no evidence for those types of games. There is no evidence for puzzles. There is evidence for learning. So if you like doing puzzles and it's challenging, I think that's great. Do them. I would say go learn a language. Go learn how to do pottery or garden or astronomy or physics because it's really the learning aspect that is important, not the, doing the same thing. I mean, I have people tell me they play crosswords all the time. It's like they've done this all their lives. They don't even find it challenging anymore. I'm like, I don't think that counts, unfortunately.
Thank you. Well, thank you very much, Dr. Tartaglia. That was amazing. Thanks for sharing, and I don't think we all have to feel the doom. I think we're all here learning, so that's positive. We can all go home and take a walk tonight and get our exercise. I'm not sure we're all going to do the marathon training, but you never know. I just wanted to take this moment to really thank all of you here. I think you've come, you have been very generous donors to us over the years, and we can make great things happen together. And with your support and with the amazing staff and researchers and doctors and scientists here, I can feel hopeful, and I sure hope that you can as well, about the future for our generation and generations to come on what is actually possible. So thank you to all of you for your support over the years. I hope that you can pick up your newsletter if you didn't already receive one in your mailbox. We have extra copies outside. And I do hope that we will see you at the next lecture series on November 19th. The staff here with our badges, if you have extra questions, we can help you get the answers. So please seek us out and we'll see how we can help you. Unfortunately, we couldn't answer all of your questions today, but I want to thank you for the time that you've spent here, and I hope you learned something, and I hope you will go and enjoy the rest of your afternoon on that walk. Thank you very much. Bye-bye.